Good morning everybody. Today I am presenting slide number 7. History given was 20 years male swelling of joint pain and stiffness. This was the image provided. Here in H&E section study we can see haphazardly interconnecting trabecular oven bone rimmed by or surrounded by osteoblasts and scattered multinucleated osteoclast like giant cells. These osteoblasts, which are rimming the trabeculae, are large, round to ovoid in shape, with eccentrically placed nucleus and moderate to abundant eosinophilic cytoplasm. The intertrabecular spaces are composed of loose connective tissue with thin-walled vascular spaces. Impression was osteoblastoma. Coming to review of literature, osteoblastoma is a rare benign bone forming tumor that by definition is larger than 2 cm in greatest dimension and is composed of neoplastic osteoblasts that deposit trabecular oven bone. It's a rare tumor and accounts for only approximately 1% of primary bone tumors. Osteoblastomas have been reported to arise in most bones of the body, but approximately 32% develop in the posterior element of the spine, 12% in the femur, 10% in the tibia, and 9% in the bones of the foot and ankle. In the long bones, they usually originate within the medullary canal of the metadiaphyseal region, but may also be juxtacortical or subperiosteal. In most instances, the tumor is diagnosed during the second to fourth decade of life. Male individuals are affected approximately twice as frequently as female individuals. Most osteoblastomas are solitary. However, rare cases of multifocal disease have been documented. Etiology. No definite etiology has been known so far. Pathophysiology. It expresses RUNX2 and Ostrix transcription factors involved in osteoblastic differentiation. Coming to clinical features, earliest symptom in most patients is non-specific pain, characterized as a dull ache that is less severe at night than during the day. Pain is not usually relieved by salicylates. Tumors located in the spine can press on the nerves, producing neurological symptoms in the legs such as numbness, weakness, or pain. Tumors can produce beta-HCG-RF as a paraneoplastic manifestation. Coming to diagnosis, in many cases the diagnosis is usually done by the tumor location, size and appearance on X-ray, CT scan or MRI scans. In X-ray, characteristic appearance is a dense shell of bone surrounding the lesion with a radiolucent nidus and surrounding sclerotic changes. In some cases, the bony shell tends to be very thin with expansion into adjacent soft tissues. Cortical expansion and destruction are common radiological findings. Definite diagnosis usually requires biopsy. This is a radiological photomicrograph to show osteoblastoma with central nidus. Here the arrow mark shows the central nidus, radiolucent area with the sclerotic surrounding. This is another photomicrograph of an X-ray of a femur showing osteoblastoma, radiolucent nidus with sclerotic surrounding. This is a resected osteoblastoma of the proximal fibula. The tumor is large, hemorrhagic and cystic, has extended into surrounding adjacent soft tissue. These are photomicrographs of biopsy of osteoblastoma. In the first photomicrograph, we can see the tumor osteoblastoma has a sharp margin with the adjacent bone. In the second micrograph, we can see haphazardly interconnected trabecular oven bone which is rimmed by osteoblasts. We can see here osteoblasts with scattered osteoclast like giant cells. The intertrabecular space is composed of loose connective tissue and thin-walled vascular spaces with extravasation of RBCs seen. This is another closer view of the trabeculae to show osteoblastic rimming. Here we can see the osteoblasts rimming the trabeculae. These osteoblasts are large, round to ovoid in shape with eccentrically placed nucleus and moderate to abundant eosinophilic cytoplasm. There may be mitosis which may not be numerous and necrosis is usually absent unless there is a fracture. Coming to variants of osteoblastoma, A variety of histological variants of osteoblastoma is recognized, which includes osteoblastoma with cystic change, osteoblastoma with cartilage matrix, osteoblastoma with epithelioid osteoblasts, and osteoblasts with so-called pseudo-malignant change. In cystic osteoblastoma, the cyst wall are composed of fibroblasts, collagen, extravascular red blood cells, scattered osteoclast type giant cells, and tubercle of oven bone that are deposited in a fashion that follows the contours of the wall. This is a photomicrograph to show hemorrhagic cystic component in osteoblastoma. Here we can see this is a cystic component with the wall of the cyst. And this is the osteoblastoma or the tumor. This is a photomicrograph to show osteoblastoma with hyaline type cartilage. In this cartilaginous variant, the chondrocytes are cytologically banal and the matrix is hyaline or chondro-osseous in appearance, with varying degree of calcification and enchondral ossification. The cartilage may merge or be sharply demarcated from the adjacent tumor bone. Here we can see the bones. Hyaline type of cartilage. This is a photomicrograph to show aggressive type of osteoblastoma. Aggressive osteoblastoma is characterized by osteoblasts that are epithelioid, being 2 to 3 times larger than conventional osteoblasts and have abundant eosinophilic cytoplasm and large vesicular nuclei with prominent nucleoli. We can see abundant eosinophilic cytoplasm with prominent nucleoli. The neoplastic bone may be trabecular or coarse and lace-like in appearance. This type of osteoblastoma can be confused with osteosarcoma, but the sharp margin of the tumor and the presence of osteoblastic rimming are helpful features in making this distinction. Yeah, this is a photomicrograph to show pseudo-malignant type of osteoblastoma. Pseudo-malignant osteoblastoma is a rare variant and contains neoplastic cells with large, bizarre and degenerative nuclei. Yeah, here we can see osteoblasts with bizarre nuclei. Even interconnecting tissue shows bizarre type of nuclei and degenerative nuclei. Coming to differential diagnosis of osteoblastoma, one is osteoblastoma, aneurysmal bone cyst, fibrous osseous lesions, and osteosarcoma. Coming to the first differential, that is osteoblastoma. Osteoblastoma and osteoblastoma appear very much similar histologically. The differentiating features are here. Osteoblastoma is usually less than 2 cm in size, whereas osteoblastoma is more than 2 cm in size, and osteoblastoma is commonly seen in diaphysis of long bones, whereas osteoblastoma is commonly seen in spine or vertebral column. Histologically, osteoblastoma is non-aggressive and central nidus is composed of well-organized osteoid and it is lined by osteoblasts, whereas osteoblastoma is locally aggressive and central lesion or nidus is less organized with greater vascularity. Pain is usually relieved by non-steroidal anti-inflammatory drugs in osteoblastoma. In osteoblastoma, it is not relieved. And the management of osteoblastoma is usually non-surgical, whereas in osteoblastoma, surgery is always indicated as non-surgical management does not help. Coming to second differential, that is aneurysmal bone cyst. Cystic osteoblastomas can be confused with aneurysmal bone cyst. Generally, the trabeculae of reactive bone in aneurysmal bone cyst are deposited in an organized fashion such that they follow the contours of the cyst wall. In comparison, the bone in osteoblastoma is haphazard in arrangement and lacks a pattern of organization. Coming to third differential, that is fibrous dysplasia. In fibrous dysplasia, the bone lacks osteoblastic rimming and the stroma is more collagenous. In osteofibrous dysplasia, the stroma is also more collagenous. The spindle cells often are arranged in a storiform pattern and also focally express keratin, features not observed in osteoblastoma. Coming to last differential, that is osteosarcoma. Notably distinguishing feature in osteosarcoma are the infiltrative growth pattern, mitosis including atypical forms which are absent in osteoblastoma. Coming to prognosis and treatment, the various histological subtypes of osteoblastoma behave in a similar fashion, although there has been some controversy regarding the aggressive type. Osteoblastoma is benign tumor. It does not have the capacity to metastasize. Accordingly, its treatment is surgical and depends on the location and size of the mass. Curettage is a common mode of therapy and is associated with local recurrence in approximately 10% to 20% of cases. En bloc resection, which is usually curative, can be performed on tumors located in bendable bones or cortically based masses. Malignant transformation is exceptionally rare. Thank you.